Welcome to this Pure Voice activity. To access the entire activity, including supporting material, go to www.purevoice.com/tzx. This activity is supported by an independent educational grant from Alexion Pharmaceuticals Incorporated.
Hello, I'm Jonathan Barrett from the University of Leicester in the United Kingdom. Welcome to this activity, From Mechanisms to Action, exploring the therapeutic potential of complement inhibition in IgA nephropathy. In our first presentation, we will explore how IgA nephropathy progresses by exploring the key drivers behind nephron loss. So how does the multi-hit hypothesis explain the pathogenesis of IgA nephropathy? Well, the four-hit hypothesis encapsulates each of those individual pathogenic steps that ultimately leads to the accumulation of IgA immune complexes within the glomeruli, and that triggering of glomerular inflammation, scarring, and ultimately loss of kidney function. The first part of this process, hit 1, is the accumulation in the serum of a particular type of IgA molecule, commonly called Gd-IgA1. It's not a single molecule of IgA, it's a group of IgA molecules that are polymeric, so IgA molecules join together, and that carry specific changes to the sugars that attach to the IgA1 hinge region. And these Gd-IgA1 molecules are essentially very sticky. They stick to themselves to form aggregates, they stick to other serum proteins, and they can be recognized by anti-glycan antibodies that can be either IgG antibodies or IgA antibodies. And these constitute hit 2, the presence in the circulation of anti-glycan antibodies that bind to this Gd-IgA1 and amplify immune complex formation. Immune complex formation is hit 3. And as I say, these immune complexes comprise the Gd-IgA1, lots of serum proteins, complement proteins, other proteins, and these anti-glycan antibodies. And it's these immune complexes that ultimately deposit and accumulate within the glomerular mesangium, where they trigger activation of mesangial cells, release of pro-inflammatory and pro-fibrotic factors that ultimately lead to loss of kidney function. And that encapsulates hit 4, the downstream consequences of that immune complex deposition. Here is a challenge question. So where does complement activation fit into this multi-hit hypothesis? Well, complement activation is one of the major ways in which those deposited IgA immune complexes trigger injury and damage within the glomerulus. IgA immune complexes can activate the complement system either through the lectin pathway or through the alternative pathway. What that ultimately triggers is the formation of complement end products, particularly C3a and C5a, which are potent anaphylotoxins that draw into the glomerulus other inflammatory cells, particularly monocytes and macrophages, and also generation of the terminal complement complex or membrane attack complex C5 beta 9. And that integrates into the cell membranes of glomerular cells, causing injury and potentially cell death. And anyone who's been to a kidney biopsy meeting looking at new cases of IgA nephropathy will see that deposition of complement component C3 almost universally goes hand in hand with deposition of IgA in IgA nephropathy. And there's a lot of evidence to support activation of the complement system within the glomeruli as being a major driving force for glomerular damage and ultimately loss of kidney function. And so when we think about what are the meanings, what are the significance of these changes that I've described as part of the four-hit hypothesis? Well, we've had a number of retrospective cohort studies that have shown that the higher the level of Gd-IgA1 in the circulation, the worse the ultimate outcome in terms of risk of developing kidney failure. Similarly, there have been studies showing that if you have high levels of these anti-glycan antibodies, there is a higher chance of developing kidney failure in the future, alongside higher levels of these immune complexes. Equally, and perhaps even more convincing, are the data that show that the more complement activation you have, the worse the outcome in terms of risk of kidney failure. Now, these are all retrospective cohort studies, but what is really exciting, of course, is that we have lots of new therapies that are capable of targeting each of these individual components of the four-hit hypothesis. And we'll be able to see by blocking either Gd-IgA1 production, immune complex formation, or complement activation in the kidney, does that indeed improve outcomes and reduce the risk of kidney failure? And that's really going to be the key test to show us the importance of these individual pathogenic markers of the four-hit hypothesis. So how has the interpretation of real-world data refined our understanding of IgA nephropathy disease trajectories? Well, we've been very fortunate over the last few years to have a number of high-quality registry studies report on outcomes in different parts of the world. This is our own study here from the United Kingdom, using data collected within the UK National Registry of Rare Kidney Diseases, or RaDaR. And this showed that in UK individuals, outcome from IgA nephropathy was poor, both for adults and children, with a median age at diagnosis of 45 years and a median age at kidney failure or death of only 48 years. And in this cohort, 50% of patients reached kidney failure or died with IgA nephropathy. And that's not what you traditionally read in the textbooks. Remembering that to be eligible to go into RaDaR, you needed to have more than half a gram of proteinuria or a GFR less than 60. So this doesn't apply to all patients with IgA nephropathy, particularly at the very benign end of the spectrum with just non-visible hematuria. But for most patients we look after in clinical practice, I think this is highly relevant. And importantly, these data are not peculiar to the United Kingdom. If we look now at some data from John Sim from the Kaiser Group in Southern California, outcomes were just as bad in his population as they were for our UK population. And interestingly, in this study, there was a significant proportion of patients who were Hispanic or Latino. And we don't have those populations of patients in the UK, but here for the very first time, we were able to see the very poor outcomes in Hispanic and Latino patients with IgA nephropathy. Again, very high incident rates of kidney endpoints, strongly supporting the idea that IgA nephropathy is very much not a benign disease and needs to have early diagnosis and early intervention if we're going to prevent kidney failure in these predominantly young people. So how does that compare to the Asian experience? Well, we've always known that IgA nephropathy is more common in East and Southeast Asia, and the perception has been it's more likely to be to cause dialysis-dependent kidney failure than in a predominantly European ancestry population. And indeed, this is what these data from Beijing show. Looking at over 2,000 IgA nephropathy patients, they showed poor outcomes. Clearly, that relationship with more proteinuria, more rapid loss of kidney function. But interestingly, in this study, the median time to kidney failure was almost identical to the median time to kidney failure in the UK RaDaR cohort. The difference was that patients in this cohort started with almost double the GFR than the RaDaR cohort, showing us that these patients were progressing on average twice as fast as the UK patients, highly consistent with the notion that East Asian patients have the disease more commonly, but also progress more quickly. And indeed, this risk is taken with them when they migrate to other parts of the world. And so how has a better understanding of the natural history of IgA nephropathy informed the latest KDIGO 2025 guidelines? Well, I hope I've convinced you that IgA nephropathy is not a benign disease. It carries with it a significant lifetime risk of kidney failure. And the only way we are going to be able to get on top of this disease is by diagnosing the disease early and intervening early. And so the 2025 KDIGO guideline update strongly promotes early diagnosis with a low threshold to perform a kidney biopsy, because that's the only way we can diagnose this disease. And as you'll hear later, an early approach to treatment with disease-modifying therapies as well as CKD therapies. And of course, encouraging risk stratification by using the International IgA Nephropathy Risk Prediction Tool, and where possible, offering patients the opportunity to be involved in a registry. Because, of course, the reason we understand so much more about IgA nephropathy today is because of all the important work that has gone into analysing IgA nephropathy patient registries. Here is another challenge question. In the next section, we will explore the therapeutic potential of complement inhibition in IgA nephropathy. So let's take a closer look at the complement system. I'm sure you remember from medical school that the complement system can be activated through three distinct pathways. The classical pathway, which is predominantly immune complex, IgG immune complex driven. The lectin pathway, which is through recognition of carbohydrate groups by lectins. And the alternative pathway, which is always ticking over, waiting to amplify the complement activation if we come across a microbial pathogen. Now, when we think about IgA nephropathy, we've got very clear evidence that the lectin pathway is activated and the alternative pathway is activated. But very rarely do we see activation of the complement pathway through the classical pathway. And of course, that's something that we see when we look at our kidney biopsies, because we'll always stain a kidney biopsy for C1q and for C3. And C1q is very rarely positive in patients with IgA nephropathy. And ultimately, all of these complement activation pathways lead to the final terminal complement pathway, which ultimately leads to the generation of the membrane attack complex, which inserts in the cell membranes of the target cell, causing cell dysfunction and ultimately cell death. So why is the kidney prone to complement-mediated damage? Well, there are a number of theories as to why this is. Perhaps the most important is we have in our body a number of proteins that block or inhibit complement activation, and they keep the complement system in check. And these proteins are either circulating in the bloodstream or are on the presence of cell surfaces. And their role is to stop complement activation from getting out of control. Now, in the kidney, we have a lot of fenestrated endothelium, a large surface area of exposed glomerular basement membrane that is prone to activate complement. And because there are no cell membranes present there, we are heavily reliant on those soluble complement inhibitors like complement factor H. And so when there are disturbances in these soluble complement regulators, we are much more likely to see uncontrolled complement activation on the surface of the glomerular basement membrane than we are anywhere else, because we still have on the cell surface those cell surface inhibitors of complement activation to do their job. There's also the possibility that actually, because of ultrafiltration, the plasma protein concentration is increased in the glomerular capillaries, making it more likely for complement activation. And the generation of ammonia in the kidney has been shown to activate the alternative complement pathway. And so what happens? What's the consequence of this in IgA nephropathy? Well, when we have those immune complexes deposit, activation of the complement system amplifies all of those downstream negative consequences. It promotes mesangial cell activation. It promotes infiltration of inflammatory cells into the glomeruli, particularly monocyte macrophages, through the generation of C3a and C5a. That can lead to uncontrolled inflammation with the formation of crescents. But also complement activation is believed to be important in podocyte injury and the development of glomerulosclerosis, and lots of new information telling us that complement activation in the tubular interstitium may well drive tubular interstitial inflammation and fibrosis. And so there's a very clear rationale for why blocking complement could impact positively on many different aspects of kidney injury in IgA nephropathy. So what is the role for complement dysregulation in the pathogenesis of IgA nephropathy? And I think I've already touched on many of those, but actually you can see, I love pictures, and you can see here pictures taken from a study from one of my colleagues and friends in London who looked at deposition of those different complement proteins reflecting complement activation and how they related to the risk of progressive loss of kidney function. And so you can see here deposition of these C3 fragments within the glomeruli. You can see that nice staining, and you can see the more of those C3 fragments in the glomeruli, the worse the outcome, the more likely that patient was going to have progressive kidney disease. You can see presence of C3d showing something very similar. C4d, a marker of lectin pathway activation when you don't have C1q deposition. Again, worse outcome. And worse outcome when you have that terminal membrane attack complex C5 beta 9. So very clear information here that the more complement activation you have within the glomerulus, the more likely you are to have progressive loss of kidney function. So in particular, when we think about the alternative pathway, and here we're looking at the regulators. You remember I said if we have disturbance in the regulators, we can have overactivation of complement within the glomerulus, particularly within those along the glomerular basement membrane. And so here what we see is the more factor H, the really main inhibitor of alternative pathway activation, the better the outcome, because these patients, if they have more factor H in their glomeruli, are more able to block activation of the alternative pathway. By contrast, if you have these CFHR1 and CFHR5 proteins, the more you have of those in the glomeruli, the worse the outcome. And the reason for that is these CFHR proteins antagonize the ability of factor H to switch off complement activation. They're working against factor H. And so if you have more of these proteins, factor H is less effective and you get more complement activation. Again, really promoting the idea that the more complement activation we have within the glomeruli, the worse the outcome, the more glomerular injury we will see. Similarly, when we think about the lectin pathway, in a proportion of patients, and that varies depending on race, lectin pathway activation being more common in Asian patients, you can see activation of glomerular injury. And here you can see all the components of our lectin pathway. The MBL, the mannan-binding lectin, you can see the MASP2, which is the major protease of the lectin pathway, C4d, and you can see here C5 beta 9. So lectin pathway, again important, but not necessarily important in all patients with IgA nephropathy. So what is the rationale for targeting complement in IgA nephropathy? Well, I hope you already know the answer from what I've been saying. The more complement activation we see, the worse the outcome. We can see from many, many different studies that the more evidence we have of complement activation within the circulation, lower levels of C3, increased breakdown products within the circulation, the worse the outcome. Now, IgA nephropathy is not like lupus. You're not going to see major changes in C3 and C4, signs of complement consumption being associated with disease. But in those studies that we've looked at, the C3 levels may well be within the normal range, but the lower they are, the more likely there's going to be progressive loss of kidney function. We know that there are changes within those regulatory proteins that control the alternative pathway, factor H, and the CFHR proteins that I talked about in the previous slide. And again, while these changes are not to the extent we see in C3G or atypical hemolytic uremic syndrome, these subtle changes are also associated with a worse outcome. So the more evidence we have of dysregulation of those controlling proteins of alternative pathway activation, the more likely we are going to see kidney failure and loss of kidney function over the longer term. And of course, the kidney biopsy data I showed you, the greater the degree of complement deposition, the more dysregulation in those regulatory factors, the more likely we're going to have progressive loss of kidney function. And perhaps one of the interesting things is from the gene-wide association studies. There's in fact a protective deletion of the CFHR1 to 3 gene, which is associated with protection against the development of IgA nephropathy. Because these proteins are absent, factor H can work much better and reduce the amount of complement activation. Interestingly, this deletion is less common in Chinese patients compared to European patients, suggesting that they are more likely to be more prone to complement activation than the European ancestry patients. Again, that would be consistent with what I talked about in the natural history. They're much more likely to have a more progressive disease course. And actually, when we look at kidney biopsies, they're more likely to have an inflammatory phenotype in response to IgA deposition, presumably reflecting increased complement activation. Here's a challenge question. So which approved and emerging therapeutic strategies for IgA nephropathy target complement pathways? Well, we have a number, and I'm going to talk about these in more detail in the next session. But at the moment, we have 3 drugs in phase 3 that target different aspects of the complement cascade. We have iptacopan, which is a small molecule inhibitor of complement factor B of the alternative pathway. We have cefaxacen, which is an antisense oligonucleotide that targets the production of factor B within the liver. And we have ravulizumab, a monoclonal antibody that targets C5 of the terminal complement pathway. Here is another challenge question. In the next section, we will review the latest clinical trial data on complement inhibitors and how they are shaping the future of IgA nephropathy management. So how safe and efficacious are recently approved and emerging complement inhibitors for IgA nephropathy? So let's first talk about iptacopan. This is a small molecule oral factor B inhibitor that blocks activation of the alternative pathway. At the moment, it is the only approved complement inhibitor for the treatment of IgA nephropathy. It's approved in the United States and in China. And we are at the moment waiting to see GFR data, and the hope is that this drug will be approved in other territories soon. APPLAUSE trial was a placebo-controlled study looking at iptacopan 200 milligrams twice daily against placebo. And we have now reported and published the 9-month interim analysis, which looked at the effect of iptacopan treatment on proteinuria in high-risk IgA nephropathy patients. And what we saw, as you can see here, is that treatment with iptacopan at 9 months led to a 38.3% relative reduction in proteinuria compared to placebo. We're still waiting to see the eGFR data, but that is going to be available at some point this year. And that will really show us how this reduction in proteinuria translates to longer-term kidney function protection. In terms of safety, remember that all patients in APPLAUSE and all patients full stop receiving a complement inhibitor must be vaccinated against encapsulated organisms, particularly Neisseria, but also strep pneumonia and Haemophilus. And in that setting where all patients were vaccinated, the safety profile was very good. You can see here on the screen, very little difference in adverse events between those who received iptacopan and those who received placebo. Here is a challenge question. The next drug that is in phase 3 is a drug called cefaxacen. Now, this targets factor B of the alternative pathway in a different way. This is an antisense oligonucleotide that is designed to target the liver, where the oligonucleotide prevents the translation of factor B mRNA into protein, effectively reducing the circulating level of factor B within the bloodstream. Now, we don't have any phase 3 data yet, but we do have a recent article published looking at the early phase data for use of cefaxacen in IgA nephropathy. It was a single-arm study, and what you can see here is that treatment with cefaxacen effectively reduced the plasma levels of factor B and the levels of activated factor B, BA, and there was an associated reduction in proteinuria in these IgA nephropathy patients. The treatment was safe and well tolerated. Remember, we don't have a placebo group to compare, but you can see the treatment emergent adverse events on the screen at the moment, and most of these were mild in severity. Cefaxacen is currently being evaluated in the Imagination phase 3 trial, again a placebo-controlled trial like the APPLAUSE study, looking at high-risk IgA nephropathy patients. Cefaxacen is given in addition to supportive care. And again, we'll be looking at an early proteinuria endpoint, at this time at week 37, to see the effect of cefaxacen on proteinuria. And patients in the study will be followed out to 2 years, where the effect of cefaxacen on rate of loss of kidney function will be evaluated. At the moment, we don't have any of these data available. Hopefully, we might see something towards the end of 2026 or perhaps early 2027. Interestingly, within this study, there's going to be repeat kidney biopsies offered to the patients to see whether treatment with sulfaxacin and blocking of alternative pathway activation alters what is going on in the kidney tissue itself, reduces complement activation, reduces those signs of glomerular injury. But we'll need to wait and see those data for the future. The final drug in phase 3 is ravulizumab. This is a monoclonal antibody that targets C5 in the terminal complement pathway. We have published phase 2 data from the Sanctuary trial, and these data showed that targeting C5 in high-risk IgA nephropathy patients led to a significant reduction in proteinuria, a between difference of 30% reduction in proteinuria compared to placebo. The safety data was reassuring, and of course we use ravulizumab or have used ravulizumab quite extensively in the treatment of atypical hemolytic uremic syndrome and in some patients with C3G. So we have experience of this drug in nephrology. And the safety profile of ravulizumab in this Sanctuary trial was very similar to what we have already observed in other indications, remembering again that all patients were immunized against encapsulated bacteria. Ravulizumab is now being assessed in the phase 3 ICAN trial, another placebo-controlled study looking at ravulizumab given intravenously every 8 weeks compared to placebo in high-risk IgA nephropathy patients. And again, there's an early readout of the effect of ravulizumab on proteinuria, this time at week 34, and a longer-term evaluation of the effect of ravulizumab on GFR out to 2 years. In this study, there's an additional open-label cohort with who have a lower GFR, so a 20 to 29 mil per minute cohort, with the main cohort having to have a GFR above 30 mils. So in what ways do the KDIGO guidelines incorporate emerging clinical data on complement inhibition to shape updated treatment targets and management strategies? Well, I hope you're all now used to this algorithm, which was in the 2025 KDIGO update, splitting the treatment approach to IgA nephropathy to those treatments that are targeting the generic downstream consequences of general CKD, and those treatments that are believed to be disease modifying, targeting those different hits of the pathogenic cascade. And of course, what we are saying in the KDIGO guideline is you must think about addressing both of these if we are to prevent kidney failure in the lifetime of most of the patients with IgA nephropathy that we look after. And complement inhibitors very much lie within the left-hand side of this algorithm, within those treatments that target the specific pathogenic hits of IgA nephropathy, specifically targeting hit 4, those downstream inflammatory consequences of IgA immune complex deposition. But there's also interesting data suggesting that complement inhibition may also protect against tubular interstitial inflammation or fibrosis, so may well have an effect outside of the glomerulus, and some even more speculative data suggesting that addition of complement proteins to immune complexes may actually drive those immune complexes to deposit more often and to cause more injury. And so it's tantalizing to speculate that complement inhibitors very truly lie on this left-hand side of the algorithm and are disease modifying, but they may be disease modifying in more than one way. They may be causing improvements and cessation of glomerular injury, both through blocking complement activation in the glomerulus, slowing down tubular interstitial inflammation and fibrosis, and modifying the composition of the immune complexes, making them less likely to deposit in the glomeruli and less likely to cause inflammation. And interestingly, these aspects of the use of complement inhibitors are going to be tested in a number of studies where we are looking at repeat kidney biopsies before and after treatment, where we are looking at the blood and looking at the composition of these immune complexes and looking outside the glomerulus in the kidney on what's going on in the tubular interstitium. So really exciting times ahead, and we may well need to reevaluate how these complement inhibitors are providing benefit in patients with IgA nephropathy. Here's a challenge question. Thank you for watching this presentation. We hope you enjoyed this activity.
This has been an activity published by Peer Voice.